Hello, my name is Dr. Christina Hawkins and I am a GP partner at the Harvard practice in Broadstone Pool. We are a practice in the Pool North Primary Care Network and we have about 12,260 patients registered with us. Pre-COVID, we were a busy practice but had an adequate number of GPs to deal with the calls and face-to-face appointments required. On a normal day, I would see about 12 face-to-face patients each session, followed by 2 or 3 emergency face-to-face patients and about 2 to 6 extra phone calls depending on the day. In our practice, there would always be one GP doing an emergency telephone triage list. So we've always been used to doing telephone triage, but not as much as we do now. Home visits over lunchtime would be divided equally, and on an average day we would do about 2 per day. We've always had 2 designated GPs to do weekly ward rounds at 3 of our largest care homes. Then a different GP would be on call covering emergency home visits and patients over lunch or between 5:30 and 6:30. When the COVID-19 pandemic occurred, we had to dramatically change our working day. Patients with possible COVID had to be seen in a specific hot room in our surgeries. This was then changed to a clinic in Wilton, staffed by GPs from 9 practices on a rota basis. We generally changed our working days to all telephone appointments, both urgent and routine. Everyone requiring an appointment had to be screened by a GP to get a face-to-face appointment. We then brought in between 2 and 4 patients for face-to-face reviews at the end of each surgery. We are doing about an average of 7 urgent phone calls and 6 routine calls per session. Unfortunately, even with this capacity, we are having about 4 or 6 extra emergency phone calls per session. Initially, people called us less and wanted to stay away from the surgery, worrying about COVID. During these months, we were dealing with lots of different problems, such as isolation queries, vulnerable and shielded patients, as well as patients with COVID-19. Over the last 2 months, the queries regarding COVID-19 have settled, but we seem to be inundated with phone calls, patients requiring urgent on-the-day callbacks. We are finding it increasingly difficult to cope with the increasing demand. A telephone appointment seems like it's quicker than a face-to-face, but to get through history, it often takes longer. Then you might still have to bring the patient in for an examination. A couple of new technologies that have helped us during these times are video consultations and e-consults. Videoing a patient means that we can cast an eye over a patient that we're not sure about on the phone, view a rash or do a care home ward round. On average, we do about 1 to 2 video consultations per session. E-consults are a much quicker way of dealing with certain problems or a patient accessing our help. Examples include medication queries or requests, photos of skin lesions, or a Med3 request. Though sometimes a phone call is still needed. We do about 7 e-consults per day across the practice. I found it difficult to have an increase in telephone appointments and less face-to-face. It is easier to develop a rapport with a patient face-to-face, and you can tell if the patient has a hidden agenda or something else they're not quite telling you. Or take pointers of how they're dressed, or sitting, or their eye contact. Telephone consultations can be quite straining and take up a lot more time, as trying to deal with everything over the phone is quite difficult. This is especially difficult for newly qualified GPs, new salaries, or locums who don't know the patients as well as GP partners or established GPs at a practice. This is what is required at present during these circumstances, but hopefully in the future we will get back to more face-to-face appointments, but probably not as many as before, kind of a halfway house. But I think the new technologies will continue to play a vital role in future general practice. At the beginning of the lockdown, we also found that patients were making unnecessary prescription requests for repeats that were not yet due or previous acutes that they felt they needed, such as antibiotics or inhalers. This created a lot of work for our repeat prescription team and subsequently a lot of phone calls for GPs. Patients were worried there would be a national shortage of medication or they wouldn't be able to get their repeats when actually needed. This has calmed down now as there is less patient concern. On average, we normally do about 1,300 script requests per week. It is clear to say that we are all working in strange times. All of these changes are much needed at present. We want to continue to work with our patients to provide the best care possible.